Good afternoon, everyone. Thank you so much for joining us for today's webinar in the pre-legislative session webinar series. I'm going to go ahead and kick us off with just a quick introduction to the series, some upcoming webinars that we have, and some housekeeping. We'll also give a little context as to what the policy boards are. So this webinar is being recorded. The recordings are going to be made available on YouTube. I've been able to get them up a few hours afterwards as of last week, so we should be good to go on that. You should be automatically muted as a participant. However, during Q&A, we'll have to open it up so that you can speak if you have a question. If you do accidentally forget to mute yourself, I will go ahead and mute you for you. So I do reserve that right. If you can, put in the chat, put your name, title, and agency. I am keeping track of that so that, if anybody needs any sort of letter that they were in attendance, we can get that taken care of for you. Let's try to hold time for questions at the end of the presentation and use the raise hand function if you do have a question. For questions, instead of using the chat, if you push the button that says more with 3 dots in it, then a Q&A box should come up. You can type your questions in there. You may already have the Q&A up on your toolbar. I think it just depends on as to whether or not you've opened that yet. This project is a collaboration between the Nevada Public Health Association's Policy and Advocacy Committee, the Behavioral Health Association of Nevada, led by our esteemed Steve Schell, who also is here today in a different role, and all 5 regional behavioral health policy boards. The purpose of this series is really to give our attendees a snapshot of what the current status is of Nevada's behavioral health system. So that way, when we are listening to bills and reading bills that affect behavioral health, we have an idea as to what's at play and what's already going on. We've really done our best to try to include speakers who are true subject matter experts, who also do not have the concern of benefiting financially or politically from participating in this webinar series. Upcoming webinars. I'm not putting any more on the calendar for now, so this is what we're going to be doing for now. This coming Thursday at noon, we have current efforts to improve Nevada's behavioral health workforce. We're going to be hearing about Be Here in Nevada, as well as the efforts of Children's Advocacy Alliance associated with workforce. On Monday, we have Emma White from the Nevada Office of Suicide Prevention coming in to give us an overview of state-level suicide prevention programs across various agencies. She's a speaker, an author, an advocate, as well as a professional. This should be really good. Wednesday, we have an update from Nevada's crisis response system. That system is currently underway for build-out and planning, so we get to hear from that project leader as far as what the game plan is and what timelines we can expect. On Thursday, the following day, Dr. Terry Kearns from the Office of the Attorney General will be joining us to give an overview of the Surge 2024 annual report. And last one in this particular series, but not least, Friday on Valentine's Day at noon, we will have an overview of the Nevada and Department of Justice agreement for children's behavioral health system transformation. So you've probably heard it in the news. Let's now get a chance to talk to who is leading that transformation project to hear what they're doing, what their plans are, and what the timelines might look like. We are going to be talking about the behavioral health policy boards today. So we have a little bit of context here for you. There's currently 5 regions. The boards consist of between 7 to 13 members, and the positions within these boards are both completely volunteer, but also represent different professions that span the entire behavioral health system. So law enforcement, public health, criminal justice system, providers, peer and or family member, the list goes on. So that's just kind of how those boards work. The purpose of these boards is really to advise state-level agencies and commissions, including DHHS's Division of Public and Behavioral Health, as well as the Commission on Behavioral Health. But the boards do have the ability to kind of jump in and advise other places as needed, usually through formal letters. Each board is allowed 1 bill draft request each legislative session. So we're going to be talking about the bills that have resulted from those bill draft requests today. And just to give you an idea of the different areas covered by these boards, we have Washoe in pink, which is just Washoe County, the Northern Board, which is there in yellow, which is those western rural counties to include Carson City, Churchill, Douglas, Lyon, and Story counties. The rural region, which is the one that I serve, there in blue, which is Elko, Eureka, Humboldt, Lander, Pershing, and White Pine counties. The southern region, includes Esmeralda, Lincoln, Mineral, and most of Nye County. And then Clark is there in orange, which includes not only Clark County, but the southern tip of Nye to include Pahrump. So you're going to be hearing from the coordinators today, as well as some of the board chairs. The coordinators we're the unofficial staff of the policy boards. And so we work to align our work with the needs of our communities, as well as with the priorities of our policy board and the funding deliverables. So we work a lot with our state partners when we're working on funding to identify how we can bring all those pieces together, so that we're not doing projects just for the sake of doing projects, and also really moving the needle towards meeting our community's needs. We also work to advocate for these communities served by state agencies. So our job is also to say, hey, this is working. Let's do more of this, or this is not working. Let's either stop doing that or change how we're doing it. We also can work with our state agencies to connect them with local organizations when they're looking to roll out projects, who is available to do what, who's poised, etc. We also are organizers. We bring different stakeholders together, usually for some sort of mutually important project or something else. And again, we are funded by DPBH, but we are all seated at local level agencies. So we have to work with the state, which is good. We can't just go rogue and kind of go in our own direction, because that could create duplication. But being at a local agency also allows us to advocate to the state on behalf of our local organizations a little bit better. Here's the current coordinators. We're also going to introduce the board chairs in a minute. So I'm going to go ahead and pass the baton to our esteemed actual facilitator, Shayla Holmes.
Hello, Shayla Holmes. I am the what am I? I am the board chair of the Northern Regional Behavioral Health Policy Board, and I'm also the director of Lyon County Human Services. So I'll get my introduction out of the way. But we're going to start with introductions of, let's go first, or maybe let's do it by region, so that way we don't confuse folks a little bit too much. So if we can start with Washoe, Steve, would you introduce yourself?
Yes, hello. Good afternoon, everyone. I'm Steve Shell. I'm chair of the Washoe Regional Behavioral Health Policy Board, and it's so great to be here today and see all of you.
Thank you so much. We're going to go to our Washoe coordinator.
Good afternoon, barely windy afternoon. I'm Dorothy Edwards, and I'm the Washoe Regional Behavior Health Coordinator, and happy to be joining you all today.
Thank you so much. We'll go to our Northern coordinator. It's a test for them. They've got to figure out where they're at.
Yep, I am muted. Hi, everyone. Sherilyn Marwood, Northern Regional Behavioral Health Coordinator. And as you all know, my chair, Shayla Holmes, is going to facilitate this. Thanks, Shayla.
I'm gonna give it a go. We'll see how well I do and how long my internet's on for. So then we're gonna move right on to our rural coordinator.
Good afternoon, everyone. Fergus Loftridge. Sorry, I may not have video. I'm traveling remotely. I'm in Elko today, so working from my phone. So good to be with you.
Thank you so much, Fergus. Fergus is our rural behavioral health policy board chair, and as mentioned by Valerie, their organizing entity, their coordinator would be Valerie Haskin, who you already heard from earlier on.
Hello again.
Doing the wave. We're going to move on to our Southern board, which I believe we have our coordinator on for.
Thank you. Mark Funkhauser, Southern Regional Behavioral Health Policy Board Coordinator. And that would be the rural and southern counties. So
Fabulous. Thank you. Oh, yeah. Sorry. Did I say rural? I meant southern. It's still rural. Just the southern rural, as Mark so eloquently
said. Yeah. Actually, it's not Clark. Let's put it that way. So just wanted to distinguish there. Yeah.
Not as far south as Pahrump and Clark, because I think that was a legislative change a couple of sessions ago, right? Unfortunately, we don't have with us today our Southern or our Clark board, which, as Valerie pointed out, is Clark County and Pahrump. And that board chair would be Char Frost, and they currently have a vacancy for their coordinator position. but they may be popping on with us at some point in time. And if they do, we'll just loop them in wherever we're at. Thank you so much to our coordinators and our board chairs that were able to make it on with us today. The work that these boards do is so important and critical to the communities that they serve. And with that, we're going to roll right into the presentations. And I think if we can stick with the same layout that we did as far as our introductions, we're just going to go by region straight on down. So Washoe, Dorothy, if you would, I think you're the presenter for Washoe County. So if you have anything you'd like to share, I think you have the ability to share now. Otherwise, the floor is yours.
Okay, thank you. You can all hear me fine? Okay, so I'm just going to talk a little bit about our board bill, SB 47. Val did a fabulous job of talking a little bit about what our coordinator's role is, and then our chair will provide some answers to follow-up panel questions, I believe. So a little history to the creation of SB 47. I'm going to read from notes so I can stay on task and don't get a little verbose, as I can tend to get. So if you remember, the Federal Mental Health Parity and Addiction Equity Act of 2008 mandates parity between mental illness and substance use disorder benefits and medical surgical benefits provided by health insurance providers or group health plans. In Nevada's 81st legislative session, AB 181 was passed, taking steps to improve Nevada's parity process, ensure compliance, and address some of those issues. We all know that in spite of legislation, both federal and state, parity laws haven't always been followed, which has continued to impact those individuals seeking and receiving behavioral health services through an equitable process. Washoe Regional Behavioral Health Policy Board voted to support efforts around parity in behavioral health, which includes both mental health and substance abuse issues. Before we determine what or if we need yet another piece of legislation that may or may not be complied with or have its own issues, we believe that we need to understand where we really are in Nevada in terms of compliance. SB 47 is a critical step towards addressing gaps in behavioral health coverage that leaves many Nevadans without the care they need. We discovered that we don't really have any clear matrices on parity data. So this bill seeks to identify where the gaps might be through the initiation of a comprehensive study of insurance parity data for behavioral health care and other medical care. By analyzing certain metrics such as network adequacy, reimbursement rates, denial of coverage, emergency care utilization, this study will provide essential insights into how current insurance policies impact access to behavioral health services. It's less about blaming or pointing fingers or proposing punitive outcomes. It's really the goal of these findings will guide the development of tailored solutions that consider Nevada's unique challenge, including its rural and urban disparities, workforce shortages, and limited insurer pool. The study would aim to develop policy recommendations that address the unique behavioral health needs of Nevada residents and ensure equitable access across the state. The study would also evaluate compliance with the Federal Parity Act, but identify opportunities for Nevada to implement innovative policies that improve care quality, reduce costs, and enhance outcomes. The goal of this, which of course, it's always the elephant in the room, finance, fiscal, it's to cover the cost of this study by working with partners to obtain grants, gifts, or donations. We've begun to meet with partners to discuss how this might look, and to this date have not received any negative feedback, but will of course be open to meeting with all stakeholders. We want this to be a collaborative process, and thus far it has been. We have a ways to go, and we've got meetings scheduled this week. We often know that studies can get an eye roll, can be stuck in a drawer. We really feel like this has some benefits, and we are prepared to go forward because the policy board believes strongly that individuals seeking behavioral health services should not face any more restrictions or barriers in coverage and services than an individual seeking care for other medical conditions. It is about equitable treatment. How'd they do, Val? Thank you all. And I look
you're still
forward to
coming in on
providing.
time.
more information. This week is kind of critical because we've got meetings set up with our partners, and our legislator, who I should have mentioned is all the boards have a legislator appointed to them, and ours is Senator Angie Taylor. So thank you.
Thank you so much, Dorothy. Steve, did you have anything you'd like to add to that, or we can move on? And I think you're up for questions. Is that what Dorothy tagged you for? You're the answerer?
Yeah. I was just going to add to what Dorothy said, Shayla. As Dorothy said, the reason this is so important to our board is I think it will be very important to all of you, is that we've been talking about parity for a long time, but what does that really mean in our state? I mean, I know we've talked about how we're in compliance with the federal parity laws, but I think we really need to drill down on that in our state and really figure out, are we truly compliant in our state? And the only way we can really do that is by gathering data. I think all of us continue to hear, situations around the state where individuals are not being able to access the care that they need. And is that part of challenges with payers, or are there other challenges? I just think it would be very helpful for us to really drill down on that. So that's one of the reasons why the board and Dorothy and I felt like we really needed to push this forward in this session.
Fabulous. Thank you so much for that, Dorothy and Steve. I like facilitating this conversation, and I just want to have this conversation about the importance of parity, because you guys are so spot on. So I'm very much so looking forward to the outcome of your guys' proposed bill. But since we're on a time schedule, we're going to move on, and I'm not going to derail the whole process. So moving on to our Northern board, we're going to pass it over to Sherilyn Roarwood to share what we're working on.
And Shayla, you'll be glad to know that at our board meeting this Thursday, 2 p.m., Dorothy will be presenting on this exact same bill. So all those questions that you have, keep in mind, and we'll ask Dorothy when she presents on Thursday. Little plug for our meeting too. All right, so the Northern region, our BDR 39-434, which became AB 60, is a kind of a two-pronged approach with the verbiage in NRS 433. My board had quite a few priorities that they wanted me to look at when we were kind of determining what we were going to choose for our legislative bill this session. And workforce development really seems to come into the table. Workforce development. So we really looked at how can we help our rural region with that workforce development. And so we took a look at NRS 433, and we looked at the Certified Prevention Peer Support Specialist. And in legislation, that career, that pathway to social services starts at 18. We know we have a lot of school districts that utilize their youth already to do some of this peer work. And so we really kind of took a look at that, meeting with NCB as well as some of the organizations that utilize peers to look at how feasible would it be to bring 16 and 17 years into this work with an ability to pay them, bill, things of that nature. So that was one part. The second part was codifying a certified prevention specialist and really giving them some skin in the game. With today's communities facing a myriad of challenges, violence, substance addiction, crime, illness, all those problems and the long-term damage they can cause can really be prevented with appropriate education and intervention. Prevention-based programs are really taking messages to those schools, workplace, faith-based organization, community centers, communities in a whole throughout the U.S. and 22 countries. So it's really an upcoming and really promising profession, the certified prevention specialist. So part of what we really wanted to do was bring that profession to codify, giving them some skin in the game, as I said. There's multiple ways that we utilize prevention specialists throughout our state, and with the coalitions up and running and doing a lot of work out there, knowing that there's a few NRSs that already are designed to use certified prevention specialists, really kind of gave us that to really say, how do we bring that profession to fruition? And it was by really adding them to NRS 433. The coalitions, the statewide coalition will off session be working on writing their regs and their codes to really align with what work they do throughout the state. So that's kind of really what we looked at, was really that workforce development. How do we make those changes that we could see? And so adding that youth language and then codifying certified prevention specialists is really where we kind of look to go. I will tell you that there is an amendment that has been submitted already for AB 60. So when that, it has not been heard yet, so I won't be able to speak about it right at this moment. But there is an amendment that already has been made that will be heard in the first hearing. So really, that's kind of where we came up with how this language, and as I stated, when we started looking at legislation, the board really had some really fine ideas of what to look at. Was it going to be that regionalization, relooking at that authority again, codifying the coordinator positions with the boards, since we are like kind of this entity that kind of exists with our board. But we really thought that workforce development was a way to go. And so with that, I'll leave it to my chair to add anything or answer any questions.
We're not to questions yet, but I don't really have anything to add to that. Thank you so much, Sherilyn, for going over AB 60. I think just to share with this group why our amended language is the difficulty in figuring out how we start bringing in our youth into these paid positions. And we struggled with that, to be honest. Like, we know it's a need, but we're struggling with the legal ramifications of what that looks like. And we desperately find it important for our prevention specialists to be codified and to give them that clarity and support of legislation that we believe in these positions, and to really build them up within our state. And we didn't want any unclarity around how we help youth become peer support specialists to detract from that. So we just wanted to get clearer in our purpose. So hopefully I didn't just make that more complicated. But we're going to move on to our rural region. And Valerie, I believe you are up.
Okay, so I did have a couple slides prepared, but I'm not going to do them because nobody else is. But so the Rural Regional Behavioral Health Policy Board's bill for this session is SB 68. There are essentially two things we're trying to accomplish with this bill. First, we are entering the Nevada Board of Examiners for Social Work, which is the licensing board for all type of social workers in Nevada, into its interstate licensure compact. The second piece is that we are trying to provide some detail to the requirements that each of the 4 behavioral health licensing boards in Nevada currently are required to send to both the regional behavioral health policy boards, as well as the joint standing interim committee on HHS during odd years for legislative sessions. So interstate licensure compacts. You may have heard a lot about that. Essentially what it does is a compact will allow, it's like a separate entity, and each of the states in these compacts have to add legislation that essentially enables them to enter into this agency or organization. Then when somebody is licensed in that state that is a member, they can apply for a multi-state certification or licensure that will enable them to practice in any of the states included in the licensure compact. So just to show you where we're at with the social work compact, I'm just going to go ahead and share this picture really quick. This is from the compact website. So as you can see, in light blue are the states that have current legislation pending to add their boards of social work into this interstate licensure compact. The ones in blue already have. And so when Nevada, if this bill passes, it would go from light blue to dark blue like Utah and Arizona there. And then when someone is a licensed social worker of any of the types of licensures that we have here in the state, they could then apply to be a part of this compact. And they may live in Nevada, but they could practice in Utah or Arizona or Colorado or Kansas and vice versa. So we have a lot of people, particularly in northeastern Nevada, down through the eastern part of the southern region, as well as into Clark County, who may be accessing providers who are in Utah, Arizona, or elsewhere. particularly if they go back and forth. So this would enable them to work with the same provider. It's great for college students who may live in one state and go to school in another. They can continue their care wherever their provider may be, if it's in their compact states either way. And it also helps tremendously for people who are wanting to move to Nevada, who are experienced providers, and who want to start practicing here, but they don't really have the time or the opportunity to really go through the sometimes or historically lengthy licensure process. We've heard nightmare stories that were, several years old now. And we know that the current and previous executive director of the Board of Social Work were working to improve those processes, but really entering into a licensure compact really helps us get access to the most possible experienced providers that we can. Also, this goes for telebehavioral health too. So for example, if someone is accessing services via telebehavioral health, they can access providers anywhere that's a part of that interstate licensure compact really seamlessly. So that's really important. Another reason why it's important on the social work side is licensed clinical social workers, or LCSWs, are one of the only provider types in Nevada who can work with people with co-occurring conditions, so mental illness as well as substance use issues at the same time. Otherwise, someone would maybe need to access two different providers with different licensures to tackle the mental health side and then the substance use side separately. So super exciting that we can do that. The second piece is, again, that reporting piece. So right now, the different licensing boards are required to report information as the number of applications that they received for licensure, the number of complaints they received about licensed clinicians, the number of investigations completed, cases dismissed, cases settled, if they denied applications, the number of applications denied, etc. What SB 68 wants is a narrative description of the processes that these boards use to collect their data, the reasons for denial of applications, because right now a number of applications that are denied doesn't tell us anything. Are these people that are being denied for like clerical issues, or are these people who are being denied because they're really not eligible to practice in Nevada and we don't want them providing services here? We can't differentiate that with a number. The known reasons for any increases or decreases in the number of applications, and then if known, the location in the state where each applicant will actually be working or providing services. So that is the second piece of SB 68. And I think that is it. Fergus, I know you're online or on the phone. Do you have anything else that you'd like to add to that?
Yeah, just for the edification of the folks listening, that our board has been active with workforce development for the past two sessions, and then including this session now, three sessions. And previously, we worked with the licensing boards that got the reporting requirements and what those nuances might be, made some improvements there with that successful passage of legislation. And then last session, we were successful in developing the Workforce Center of Nevada, which is now housed with the University of Nevada School of Medicine in Las Vegas. And they have the Be Here Nevada, which is modeled after some work that was done in Nebraska previously. So we're constantly working to any barriers that might be out there when it comes to getting our professionals licensed and serving our population, both rural and urban. So we try to take that homogeneous approach to things. So that's just kind of the history of where we've been. And now we're at a point where we just need to step it up a little bit with the licensing boards in our bill to get that standardized reporting mechanism.
Fabulous. Thank you so much for that information, Valerie and Fergus. We excited I saw Sarah Hunt with Be Here is on, and so I know that was a outcome from your guys' prior legislation, and so I know you guys are doing great stuff in the workforce arena, and excited to see what comes of SB 68 as well, because I really want to know that narrative data too. We are going to move on. I'm not going to mess it up again. Mark, you are the Southern Regional Behavioral Health Coordinator. So if you can go ahead and present to us what's going on with your guys' legislation this session.
Thank you, Shayla. Sounds like workforce is the theme of the day, and that's the theme for Nevada, as rightly so. It's not going to go away anytime soon. I think our board actually looked at that as well. And actually, our bill relates to workforce and access to care. So I think the main thing to remember about the Southern Regional Policy Board's bill, and I put the link in the chat, is it's around secure, non-emergency, secure behavioral health transport. So the key terms there would be non-emergency. So it's not like an ambulance run and actually a lot of the EMS workers and law enforcement officers are actually already doing this kind of transport, which is maybe part of the concern. But what we're asking, there's already a statute on the books that's not being utilized. Actually, no vendors have actually finalized the application process, and none of them are actually currently providing this. And so this kind of transportation is different than the non-emergency medical transport that you often hear about, which is more around just healthcare in general. But this bill asks for Medicaid reimbursement for certain distances traveled while going to pick up and returning from dropping off a patient. And so they call this loaded miles, which is when the patient is in the vehicle, and unloaded miles when the vehicle is being, on the way back or to without the patient in there. Currently, there is no Medicaid reimbursement for the unloaded miles, and that's part of our concern. I did listen to a presentation by the Health and Human Services, and Medicaid talked about actually adding unloaded miles to the medical transportation as well. So they're looking at that. So that's what we believe is a gap in the incentive for these providers and these vendors to actually sign up. So they'll essentially be getting paid for the to and from. The other part of this bill requires the director to apply for any federal authority to help support this, necessary to increase by at least 15% in the rate of Medicaid reimbursement when the pickup location or the drop-off location or both are located in a county whose population is less than 100,000. So that's all of the rural and frontier counties, all the counties except for Clark and Washoe. So that's at least 15% bump for rural and frontier transport. The other component is at least 10% for all other non-emergency secure behavioral health transport Medicaid services. So that would cover the urban areas as well. So that would help them as well. Because as we all know, a lot of these vendors and these providers are going to be coming out of the urban areas anyway. And that's part of the problem, is that the more intensive services and often with the behavioral health, workforce shortage and actually a provider shortage and a shortage of services in the rural and frontier areas, this kind of transport makes it even more critical, not really just for like inpatient residential treatment, which is, people usually have to go to urban areas to find that, but also if they happen to need to go for other kinds of behavioral health appointments. And so what we looked at was all of the things I just mentioned, and also a lot of times these patients are held in the rural critical care access hospitals, which our employer, Nevada Rural Hospital Partners, we support them, but they don't often have the space or the training or the staffing to hold these patients in those facilities. And sometimes they're actually held longer than what they need to be, either because they can't find that transportation or sometimes because they can't find an open bed or a matched bed. And right now, we believe that there's an undue burden on local government with EMS and law enforcement having to transport people long distances. That leaves them with less coverage in rural areas, and oftentimes they're understaffed and underpaid anyway, or they have to pay overtime for these folks to transport out of area. And the other big thing about that is we also believe that there's less trauma responsive care and a stigma for somebody who has to be transported in the back of a squad car, perhaps, because they have mental health issues that, especially when there's no crisis, or if EMS has to. And we're not saying that, because those professionals out there already doing this do the best they can, and they try to work with people. But let's face it, behavioral health issues are a lot different than some of the, things that the law enforcement and EMS come across with regular medical care or criminal justice. So anyway, that's kind of the overview of our bill. There's other components that we are looking at, but I think I'll just leave it at that.
Fabulous. Thank you so much, Mark. I mean, we could all probably attest to some horror stories on transportation, and being successful in getting an increased rate might actually get us a provider willing to do it, because that's always been the battle. So I appreciate you guys taking on that mountain. because that's what it is. It's a mountain in between. Okay, so we're gonna move on because we don't have Clark County with us today. So you guys have heard from all of our present behavioral health policy boards. You can always go to the policy board website to find information and connect to your local policy board and see what they're working on. I believe that's been put into the chat. All of our presenters have also posted the link to their legislation in the chat, which is pretty cool. So, so check out the chat if you haven't already. But with that, we're going to move on, and I'm going to do just a round robin request to have some questions answered generally in regards to what's going on with each of the policy boards. And then I promise we'll get to Q&A at the end. I see a Q&A in there already. Hopefully we've already addressed your question regarding youth, but if not, we will. That's what's going to keep you here till the bitter end. So with that, we're going to start again with Washoe. So both to either Steve and or Dorothy. If you guys could take a minute and share what are your board's policy priorities in general, perhaps not related to your legislation, because we know that's the one that rose to the top, but what are some other priorities you guys are working to address as a policy board?
Thank you, Shayla. I can take that, and Dorothy, please chime in if there's anything that I get to mention. But probably our biggest priority is the crisis response system. I know that probably speaks to all of you across the state as well, but that's what we've been very focused on for quite some time. With 988 in our county, the mobile crisis response teams, and then our crisis stabilization center that is opening on February 20th. So that's probably been our biggest priority. Number two is workforce development, as all of you I know can certainly attest to. And then the third is just continuing to look at our overall resources in the region and making sure that we have the right access at the right time. So those are probably the three key areas for us, Shayla.
That was rolled up beautifully. You got the thumbs up from Dorothy, so I don't think she wants to add to you. So not to put you on the spot, Sherilyn, but you want to share what we're doing in the northern region in regards to our policy priorities outside of our existing legislation?
Would love to. We have a very active region. I'm not going to lie. They keep me busy. They keep me humping. Definitely, transportation is a huge issue with every rural region, and we're going to ditto that probably all the way across the board. With that, looking at that resources, service providers across continuum, but really a focus on that youth and elders. A big piece for my region, most of them have the behavioral task force meetings that meet once a month. Deflection and diversion programs have been a big push for that. And that really kind of leads into where Steve was talking about that crisis response. Having those deflection and diversion programs is really important, especially our mobile crisis teams or MOS teams. Lyon County, Douglas, Carson, Story, they're kind of all doing their own little way team-wise to do a response team. So they're being really creative, and I love that we're looking at it and thinking, how else can we think outside the box to do this kind of work? And so then, of course, social determinants of health is a big, huge issue as well. Just always thinking about how do we work in all of those sectors. And then a big push with homelessness out in our rural region, and with our counties being close in their what am I trying to think of? They're close, but they're not close, and so we have a lot of times we have constituents going from one county to another when it comes to services and stuff like that, looking at that transportation to get them back to their counties where they came from. So things of that nature have been a big push. Of course, workforce development, I think you're going to hear that probably across the continuum as well, because we are lacking so many services and resources out in our rural region. But they're mighty, and they work hard to find resources. I won't lie. I'll leave it at that, Shayla, if you wanted to add something to that.
I think I would say we're close in partnership, but not in miles. Yeah. Zoom is great because we're all in the room together and you wouldn't even know. The only thing that I think the workforce, but our board has been very focused on developing our lower level workforce and that prevention piece and how can we do more with less. The resource struggle is real everywhere, but when we've got folks, way far out, sometimes the CHW, the community health worker, is the only one that can get to them. So how can we train them up, build them up, all those good things. So I'm going to move on to the rural region priorities. Valerie, you're on the spot again.
Thank you. So Fergus is again joining us by phone. So he asked me to go ahead and start out. The Rural Regional Behavioral Health Policy Board is actually going to be reviewing their policy priorities for this legislative session at their meeting this coming Wednesday at noon. That meeting information can be found on Nevada Public Notices as well as nvbh.org. But that aside, traditionally the policy priorities of the board have been workforce development. Obviously, that's where the majority of our bills have really focused. Looking at that insurance parity and particularly looking at ways that we can help those who may be on fee-for-service Medicaid. Previously, I believe it was last session or somewhere in the interim, DPBH did open up the discussion and open up a call for proposals from different companies for a managed care organization that would specifically serve rural Nevada. So then we would have more people in that fee-for-service model more people in that managed care model instead of fee-for-service, which would open up a lot of doors to getting additional care as well as step-down services. And you want to talk about a lot of miles, when you look at the different regions, mine's geographically the largest, definitely not the smallest population. I think Mark has that. But we have about 100,000 people thereabouts within that huge space. And so when I'm talking to other states about some of our issues, it's like, no, it's an hour on the freeway between communities going 80 miles an hour. Mm-hmm. And that kind of boggles their mind. So the other piece is really making sure that any policies that affect behavioral health in general also take into consideration the needs of frontier and rural Nevadans. And that really serves both our communities that Sherilyn and Mark and I serve, but also Dorothy's community, Reno and other Washoe communities, as well as Clark, because if we're able to get people the care they need in a timely way, that takes a lot of burden off of the overflow that goes into our other counties. So the crisis stabilization centers, looking how we can do that, working with our state partners on that sort of thing, trying to identify different ways where we can make some of these really great evidence-based practices accessible, given our resources and staffing out in the rural counties. Fergus, is there anything else that you would like to add?
No, you summed it up very, very well for where we're looking at. And I think all of our boards, um, you'll see that you drew circles of what they were concentrating on. They all overlap one another. So we're all in this together. And, you know, that's the power. I think the great thing that we have is that the communication between the boards. So they're not just doing these legislative issues and concerns in isolation. It's with their partners and our fellow uh, coordinators. So I think that's important for the listeners. Thank you, Val.
Oh my gosh, Fergus, that is so beautifully put, that we are all in this together, and that we all do have amazing impacts on cross constituency there, for lack of a better word. With that, we're going to move on to our Southern Policy Board. Mark, you're on the spot again.
Well, I could say ditto. I've thought a lot about the geography of Nevada, working on this transportation, and we have Vegas and Reno and Carson all over here, either on the south or the west and north, and then we have this vast land, and I just Googled the top cities in Nevada, and if you throw in Las Vegas or West Las Vegas and Henderson, you just, it takes a while to get down to like Pahrump and Elko and some of those other areas that have larger populations. And like Valerie said, I look at her region, it's, I often think about, because I'm based in Reno and traveling to the south, but that region that she has up there I've not been up in that area much, but I do think that those are major obstacles, and that's why the transportation and the behavioral health workforce and access to care and things like that are so vital, even to the urban areas. I'm sure we've looked at peer support and community health as well. Those are big supplements to the clinical shortage, that's going on in the state. Obviously, hospitals, rural hospitals are a big focus here at NRHP, and I serve a region that really only has 2 hospitals in the 4 areas, not counting Pahrump, which is actually in the Clark region, and even Tonopah and Pahrump, they're in the same county, but it's almost like they're in 2 different counties because of the distance. And there's no hospital up in Pahrump, and it's in the south central area there, so that's definitely creates some concern for those folks, and the distance they have to travel. Other things that our board is looking at is, Valerie mentioned the data assessment, collection, reporting, things like that, and how there are issues with that, maybe availability or barriers to that kind of collection and the complexity of all that. But the big things that we're looking at regarding, we're going to be looking at all the policy board's bills, next week in our meeting to try to, provide some support for the other, policy boards. And when we think about gaps and barriers and needs, we are looking at, how we can, this bill can supplement maybe mobile crisis on a state level, or the managed care organizations that roll out that could help provide some transportation for those folks who do get those contracts, and the people that want to provide the mobile crisis. Because I think a lot about, how do we bridge telehealth with in-person services, and are we over relying on telehealth? And we have to some degree, because we don't have the in-person services that we need. But I think if we over rely on telehealth too much, we don't ever get the on the ground support that we need in the rural and frontier areas. So I think there's a real catch-22 there. And so that lack of in-person services, and then how do we provide that continuity in the, maybe expand telehealth, but also not get too dependent on that. So where we don't ever get people, out there to actually work on the ground in those areas. So that's
so true, Mark. Thank you so
right.
much for sharing access issues and transportation and All of those things are super important to our most rural communities, but all of them in general. With that, I'm going to put you guys on the hot seat. I'm going to give you guys just a minute because we've got 10 minutes left and we want to give chance to get to that Q&A. So each of you guys have 1 minute and I'm going to hold you to it. We're going to like buzzer you. I'm going to have to find a buzzer sound on my phone. But here we go. If you had your way, what single change would you make to behavioral health system to improve its effectiveness in connecting people to timely, appropriate, high quality, and access treatment? So really, if you had the perfect ability to wave your magic wand and make this system better, what would you do? You've got 1 minute. Dorothy, your time starts now.
Well, probably as with most of us, we'd start with funding because funding's always the elephant in the room and we can't do anything without it. And so funding to expand our crisis response system, which would include a system we're kind of trying to address with our frequent utilizers that cross all of our law enforcement, judicial, behavioral health, private, public. And support along with that funding. We need high level support. We need nonpartisan support. We need everyone. So you're asking me for my dream. We need everyone to lay aside their red, blue, purple, or polka dot and agree, come to the table. I'm a Pollyanna. So that is what I see the biggest barrier. Funding and then the support of funding. Prioritizing behavior health. That's my pie in the sky. Washoe's doing great, but and then again, addressing the facilities that we have. We've got no resources and all the policy boards are doing amazing, and Val's team with the workforce, all of that contributes. But if we don't have funding, sustainable funding, we can't do it. So that's my pie in the sky. And I yield back to you, Chair.
You got no time to yield. So you did great. So Sherilyn, I'm gonna make this more complicated for you. So if Dorothy got her pie in the sky and got all the funding in the world, there you go. Now what would you ask for to make your behavioral health system the best it could ever be? 1 minute starting now.
Well, first of all, you took the word right out of my mouth, Dorothy. Funding. I think if I were really to think about that too, if we had that funding to do anything, of course, hand in hand, it's workforce and transportation. If we've got the workforce, we don't need the transportation because we have the workforce. If we don't have the workforce, we need the transportation. So I think those are two big areas that fall hand in hand. If one's solved, basically the other one potentially, but workforce for sure. And I think greater oversight. And I hate to use that word oversight. Maybe it's review, but just on our programs that we have out there, just making sure that we are doing what we're saying we're doing, making sure that overview, that review is available so that what we are putting out to our constituents is truly what we want it to be as a state. So
perfect. Thank you, Sherilyn. Okay, Valerie, you've got the same. If we had all the funding in the world and then we addressed access and transportation, what would you do to make our system just absolutely perfect?
All right, my magic wand would create some sort of system. We have the pieces of it right now, but it's not together, where we can have true collaborative care amongst providers for each person. Seamless communication, everybody's trained, all agencies, all organizations, all provider types are on the same thing. So there's no issues with people being lost in the cracks, so that we can get people to the care they need and do appropriate discharge planning when they leave higher level care, so that they can get into that lower level care. And there's communication with people who were there on the front end, how they ended up in the higher level care anyways. And everybody knows what's going on in an appropriate, HIPAA protected and HIPAA compliant way.
Love that. Can I get a amen? Yes,
drop the
to all
mic.
of these three things. So Mark, I hate to put you on the spot being last, but your magic wand, you've got all the funding you ever wanted. You've got access and transportation, and now you've got amazing collaboration happening with seamless communication and discharge planning.
Yeah.
what's your
What's left?
wand get
Oh, there's
going
plenty
toward?
left. Yeah.
Yeah.
I think about these peer respite homes. If we had one in every county where people could go to get some lower level services after the crisis, and since we're struggling with housing, and then I still think if we also had regional transportation hubs or more intensive services out there, we need clinical services. Obviously, that's part of the uh, problem, but I also don't think that we're relying on peer support, but we don't have enough peers in the rural areas, or we can't find them and get them trained and support them, and we're not paying them enough. And I think that goes for community health workers as well. So.
Oh, thank you so much, Mark. So true. Okay, Fergus, I left us board chairs for the last. So with your magic wand, what would you do for our behavioral health system?
All of those are very good and absolutely can support every one of those. But one of the things that we've lacked for centuries has been top-down leadership addressing the behavioral health crisis, and I emphasize crisis, that we have in the state of Nevada. And with that, top-down leadership that's adequately funded within the state's funding, we can do these other things. We have the coordination. We see that genesis going forward with our policy boards and with all of the folks that are on this call that are at the grassroots efforts doing that. But what we're lacking is that top-down leadership to make it happen.
So true. Thank you so much for bringing up that second elephant in the room next to funding. For me going last, super quickly, my pie in the sky dream would be that we actually got to behavioral health is health, and that we address behavioral health as we're addressing health. And you know what we really need for both of these systems to be beautiful and really just take care of our people as a holistic human is insurance overhaul. We have to get rid of our 15-minute billing increments. We have to make it profitable for providers to be able to look at the whole person, connect with everything that they need, and want to take the time to listen to them, because they're going to make the cost of their living and the livable wage during that time to fully listen to that human in front of them and take the time to give that person what they need, because they're there and it took a lot to get them there. As we heard, transportation is an issue and access is an issue, and I finally got to this LCSW. Now please just give me my time with them and get it all done in as few sessions as possible, because it's going to be profitable for everybody that way. So that's my dream, is that we have an insurance overhaul. MCOs are going to be interesting, and I'm excited to see what benefits they bring. But I think as a whole, as a nation, Nevada included, we gotta overhaul it. I'll get off my bandwagon. That'll hold myself to the same time restrictions as everyone else. So with that, we have 2 minutes left. I want to thank everybody for being on this panel, for being willing to give your time, not just to talk today, but also the time that you take in your daily work to make all of this happen, because it certainly doesn't even happen in 40 hours a week. So thank you for giving us one of your very precious hours. Thank you to everybody that's participating and listening to us talk, that's hung out with us till 12:58. At this point in time, we're going to open it up for questions to you. We can run a little over for some of us, and happy to answer your questions, but I'm going to stop talking to give you all of the 2 minutes you need. So raise your hand if you want to ask a question and or put it in Q&A.
Dr. Jill Mannett had something in the chat for Sherilyn, or in the quick Q&A.
I did see that. So Jill, you are still on with us. I'm going to go ahead and read your Q&A. It says, thank you for all of this helpful information. My name is Jill with Be Here Nevada. We're excited to have you, Jill. I have a question for Sherilyn with the prevention specialist position also be available to use, similar to the proposal for peer support. I think that this would be very helpful for recruiting young people into the field. Thank you. Sherilyn, that was directed at you.
Thank you, Jill, for that question. So the amendment that was sent into the Assembly of HHS, Health and Human Services, has to do with removing that youth language. So if we're looking at that certified peer sports specialist or prevention specialist, I'm sorry, they're going to have to be 18 years or older. And for that internship, 16 and 17, we're going to hopefully look at that maybe next session, do some searching and researching and really kind of figure out how we can really make this beneficial for our youth to do this work. Without putting them in any kind of, harm's way or anything like that. And so when the question came up about that civil penalty, it really became a necessity to kind of pull that language to really look at what can that look like, understanding how that penalty may be imposed on a youth who's doing this work. So the quick answer to your question is, they ought to be 18 to do this work. So if they're still in school and they're 18, they can do this work. If not, it's 18 for certified prevention specialist. Sorry, Jill. We tried. Next session, maybe.
Yeah, still lots of cool stuff that can happen there. I think there's still a way to inspire the youth towards this career path without giving the ability to pay them, although everybody's got to get paid. So any other questions, as we are a minute over, but we're happy to give you our time. Don't let that hold you back. We still have a couple attendees hanging out with us. So if you've got anything lingering, don't be shy. All right, they're dropping off. I think we don't have any questions. Again, I appreciate your guys' time. And if anything pops up as you're processing, I'm a processor. You can reach any one of these coordinators or any of these board chairs. You can find all of our contact information on the Health Policy Board's website. We've got open meetings. You can always come and ask us questions at open meetings. So, put us on the spot there during public comment. I appreciate all of you and thank you so much.